Hello, this is David. So, in this clip, we'll try to model the sequence of events in early onset severe IUGR and see how these relate to the fetal monitoring parameters that we discussed in prior videos. So, our conceptual model is that the initial problem, and this is a problem that starts in the embryonic phase, really, in the embryonic stage, is a problem with placental implantation. So that the initiating, let's say theoretically, the initiating biological problem is a problem with the implantation, the interface here between the maternal and fetal site. And the story goes something like this. You have these intermediate trophoblast cells, and they invade in and remodel the maternal spiral arteries. But in the event of IUGR and preeclampsia, for whatever reason, these intermediate trophoblasts don't properly remodel these maternal spiral arteries, and they fail to properly convert the maternal spiral arteries to proper low-resistance circulation. And that has something to do with the nature of the placental implantation. So the phase 1 problem, which is the problem that occurs in the embryo, much earlier than we could really measure anything to know that there's a problem, is a problem with implantation. The next thing is, because of that, in this model, is that there's improper remodeling of the spiral arteries, and that ultimately leads to the first thing that we could measure: high resistance and high systolic to diastolic ratio in the maternal uterine artery. And going back to our model, this is the maternal side of the circulation, and this is the fetal side of the circulation. So looking now at the maternal side of the circulation, these spiral arteries are connected, of course, to the uterine artery, and that uterine artery is sort of seeing higher distal resistances because of lack of proper remodeling. So the first thing that we could actually measure is parameters that correlate with increased resistance in the maternal side of the placental bed, and that would be things like increased systolic to diastolic ratio in the uterine artery, and increased pulsatility index. And in fact, that's the first measure, and that's the measure that we could actually see in the first trimester. And this measure, because it's an early measure, is not a measure that tells us that the fetus is at imminent risk or imminent harm, because the fetus isn't yet at imminent risk or imminent harm. IUGR is a progressive problem, and the problem is really just starting, or it's beginning to start or beginning to set in. So what does this early test tell us? What the early test, this problem with the systolic to diastolic ratio, or the pulsatility index in the maternal uterine artery, tells us that this segment of babies who have this finding are more likely to have true IUGR than to be, for example, constitutionally small if the babies have small growth. So in other words, this test, the increased pulsatility index in the uterine artery in the first trimester, helps us determine which babies are likely to have the true biological pathology of intrauterine growth restriction. So it's sort of almost like it helps us with selection. The next thing that happens in our model is the fetus response. So we have the increased resistance within the uterine artery, increased resistance within the spiral artery circulatory bed of the placenta from the maternal side, and the fetal placenta is trying to grow, but it's not getting as good exchange from these maternal vessels because the blood is coming in at high resistance and maybe there's less maternal blood. And so the fetus, according to this model, and this is sort of where Peter Kaufman's ideas come in, the fetus feels this sort of relative lack of supply and starts to undergo more non-branching angiogenesis and less branching angiogenesis. So it's a different type of placental growth. So in this model, the first thing that happens in the fetal side, so it's number 3 in our sequence of pathogenesis, is that there are changes in the fetal vascular modeling, but here is the important conceptual part. First, they occur in the distal villus portion of the circulation. So the fetal reaction starts here. here in the distal villus tree. And at this point, you may not be able to measure anything in the fetal villus circulation because we don't really have, it's too small. These capillaries are too small. There's nothing you could really measure sonographically. I'm not talking about serological markers. But there's not much you could measure serologically here in the fetal circulation. You could measure the maternal circulation here. But at this point, there's not much you could measure in the fetal circulation. There's really higher resistance in the distal villus fetal bed. But the next thing is that the changes are felt. I put it in quotes, that the changes are felt. That this increased resistance in the distal villus tree translates to increased resistances first in the chorionic arteries. And I'm showing them here. These are the chorionic arteries. Here I'll show them again in another color. We'll show them in blue because they're deoxygenated blood. So the next thing that happens is that there's increased resistance in these chorionic arteries, because they're sort of the next stage upstream of the distal villus tree. At this point, it can theoretically be measured. It's not done clinically, but it's done in research. And my mentor, Dr. Andre Gruslan, who's a maternal fetal medical doctor at our institution, has been able to show that parameters such as pulsatility index in the chorionic vessels can be detected earlier than changes, for example, in the umbilical arteries. So the change is seen first here. And what do you see? Well, of course, conceptually, the first thing that you would see is because of the increased resistance, what you would start to see is this sort of change where you have a greater systolic peak and a bigger diastolic dip. So a change in the pulsatility index. But then as the problems progress, the next thing that would happen is the resistance is so high that you could imagine that the energy of overcoming the resistance is almost expended during systole and the early part of diastole, and you start to get problems with flow during the later parts of diastole, up to the point that you could actually get flow reversals, so reversed end diastolic flow. But first here. The next thing that will happen is that the changes are felt in the umbilical arteries. So that what happens is those things, let's say the fetal pathology will start here in the distal villus tree, progress up to the chorionic vessels, and now it's felt in the umbilical artery. So that will be the next step. And that is the point, to go back here, where you start to see increased pulsatility index and ultimately reverse end diastolic flow in the umbilical artery, and that you could maybe, let's say, in severe early onset IUGR see it as early as 20 weeks or so, or slightly later. So that's the next thing. The next final thing is, if you could imagine, so now this fetal right ventricle is pumping into this umbilical artery toward the placenta against very high resistances. Because of that, the pressures in the right ventricle are higher, and ultimately the pressures in the right atrium are up. Because the pressures in the right atrium are up, you now start having increased pressures in the fetal venous circulation. Now, normally, as you know, for most of the cardiac cycle, blood returns to the heart like so. But if the right atrial pressures are extremely high, you could imagine that maybe during a portion of the cardiac cycle, the blood will actually go backwards in the veins. And this is sort of analogous to what the ultrasound will see with the ductus venosus, the A-wave reversal. And this is the final step. So you see that the progression, the first things that we could measure are changes in the maternal circulation in the uterine arteries. The second thing that we would see, but this is more research, are changes in the chorionic vessels. The third, in the placental chorionic vessel, so this would be maternal, but this is now fetal. The third thing we could see are changes in the umbilical artery, and even within the umbilical arteries is a progressive litany, where first we start with increased pulsatility index, increased resistance, increased systolic-diastolic ratio, and ultimately we get to reverse diastolic flow, abnormalities of end diastolic flow. And the final thing we see, the fourth measure, is problems in the venous circulation. In the fetal venous circulation, the manifestation of increased sort of pressure and resistance would be A-wave reversal in the ductus venosus. So because this is a progressive litany, this feature will be more of a marker. That the maternal, for example, uterine artery is more of a marker that helps us determine who has biological disease. Whereas these later markers, such as reversed diastolic flow in the umbilical artery and A-wave reversal and the ductus venosus, these are late markers. These markers tell us that things have really progressed. This baby is at risk. And in fact, we know particularly with A-wave reversal in the ductus venosus, and as you can see, that's almost like the last change, that when that happens, the baby is at severe imminent risk. This very often leads to an urgent cesarean section, and there's literature showing that these babies with A-wave reversal can undergo sudden demise. And incidentally and parenthetically, I've wondered if that increased venous pressure is also what causes the thoracic petechiae that we see in some autopsies of intrauterine fetal stillbirth. So that's really the progression. And where I think that there could be grounds for modeling is to try to model the phenomenon of increased pulsatility index and reverse end diastolic flow in the umbilical artery, especially noting that it's probably first seen in the chorionic vessels and it's a consequence of changes or different growth or altered growth in the distal villus tree. And the form of the altered growth is very likely to be this kind of branching versus non-branching angiogenesis, where the placenta will sort of say, you know what, I'm not getting enough from the spiral arteries. I'm going to take this portion of my branch and I'm going to turn it into an exchange unit, but now it's sort of out and it can't contribute to further dichotomous branching. And so too, let's say you model and you say, okay, now I've taken this guy out of commission and he can't contribute to further dichotomous branching. And this is the way, this sort of Kaufman model, how the distal capillary tree is altered, and it would be really nice, I would urge anyone to try to mathematically model how that would change, and also using fluid dynamics modeling, try to see how that would change the resistance, first in the chorionic vascular circulation, and ultimately in the umbilical arterial circulation. So what I'm really calling for here is people to integrate this sort of conceptual model of branching versus non-branching angiogenesis and use that to try to model progressive propagation of increased resistance and the sequelae of increased resistance beginning at the distal arterial vascular tree of the fetal placenta and moving upwards to the proximal arterial tree of the placenta. And that's really what I'm asking for. And if you remember, it would also be nice, I think, to also try to model branching versus non-branching angiogenesis in terms of scaling of fetal metabolic demands. Those are the two things, those are the two realms of mathematical modeling that I would really urge people to do. Once again, to take this model of branching versus non-branching angiogenesis and use it to model A, the fluid mechanics of this sort of proximally propagating increased resistance and its sonographic sequelae, as well as to try to use this model of branching versus non-branching angiogenesis to try to understand metabolic scaling, which we discussed on a previous video, how the fetus metabolic needs increases and increases probably exponentially, and there could be a point at which the fetal needs basically outstrip the capacity for further scaling, which is probably the reason why small placentas are dangerous. So with that, I'll end this segment. Thank you so much, and please feel free to use these ideas and develop them in any way possible, and I'd love to see somebody take this up. Thank you so much.